morning. Thank you for joining us today for our webinar, Better Healthcare Data for Better Benefit Decisions. I am Elena Cambizzi, Senior Vice President of Business Development and Strategic Marketing here at the Alliance. We're excited to have so many of you join us today. You're all in mute mode, but we still want to hear from you. So please use the chat feature to ask your questions or get help with any technical challenges you may be experiencing. Please note that the presentation from today's event will be made available on the events page of our webpage. We will also email a link to all attendees next week. First, a big thank you to our executive sponsor, .com Therapy. They provide direct therapy and education to schools, health systems, and community programs online. Their mission is to make therapy available to everyone and everywhere. To learn more about them, please download their handouts via the handouts drop-down on your screen. We would also like to thank National Cooperative RX and Delta Dental, our year-long platinum sponsors. We appreciate all of you. Your ongoing support enables us to continue to bring these valuable programs to you and our employers. Today, our goal is to ensure you know the data that's available to you through the Alliance and other sources. Then we'll focus on how to use the data by talking with a panel of self-funded employers and partners to discuss how they're using data to make better benefit plan design decisions. Before we start, I wanted to say just a few words about why this topic is so important. As discussed at our spring symposium, healthcare prices are too high and employers need to understand where their healthcare dollars are being spent. Transparency is an important topic in healthcare right now, particularly with the passage of the Consolidated Appropriations Act, or CAA, which states that employers have a fiduciary responsibility as plan sponsors to manage their health plans appropriately. This is why you need to access quality data and need to be looking at it regularly. Thankfully, at the Alliance, we can provide it, and we have your back. So now I would like to turn it over to my colleague, Ryan Peterson. Ryan joined the Alliance in 2013 and serves as Manager of Analytics, where he leads the teams responsible for the development and maintenance of operational software, dashboards, automation, and analytic packages, which guide our provider contracting and employer members' benefit strategies. Prior to joining the Alliance, Ryan led technical services at Epic in Madison, and before that, he was a senior staff engineer and ballistic missile defense lead analyst for Johns Hopkins University Applied Physics Laboratory in Laurel, Maryland. Ryan, welcome. Thank you so much for taking time this morning. Over to you.
Great. Thanks so much, Melina. And I am excited to have this opportunity to talk to you all about data and some of the tools that we've developed and how we can make them useful to you. So let's see if we can get things going here. So I wanted to start today with a philosophy that undergirds what the Alliance does. And that philosophy is that no one provider is the best at everything. No provider has a monopoly over the best care. And that has driven some of our contracting philosophy. Because of that, we've chosen to contract with a very broad network. We have multiple competing providers in regions like Rockford and in Madison and in Milwaukee and Wausau and Eau Claire, where we're not just contracting with one provider in that region, but multiple. Additionally, we have made sure that our contracts allow for the steerage of care for specific services at whatever provider that we want to use. There's no exclusivity arrangements in our contracts. Finally, within our contracts, we make sure that all of the claim information comes to the Alliance. And that's important because as we'll talk about, data, these raw bits of data are what are going to be driving a lot of the tools and insights that we can deliver as part of the Alliance. Finally, as we look at our network map, I did want to call out, we have continued to work with partners to both broaden and strengthen our network with Trilogy and WPS. We'll move on to the next slide. So I talked a little bit about Data being the currency that's needed in order to drive change in healthcare payment reform. We need to know how claims are being billed today in order to inform how we can make changes to improve things going forward. We at the Alliance are one source of data. We receive all the claims data for all of the participants of the Alliance, and all the providers that they work with. All that comes to us in the form of medical claims. We get about 4,000 to 5,000 of those claims every single day. They go into a data warehouse. There's about 10 years of history that's actively queryable, that we can run any sort of analysis we can dream up, and a team of analysts ready and prepared to make intelligence out of that data. We recognize that that is great information to have, but it's insufficient. We supplement these raw ingredients with data from the Wisconsin Hospital Association, where we receive about 700,000 claims across the state as we consider the outer reaches of our network where we don't have a lot of claims data, where we get about 700,000 claims every single quarter. We've got a 20-year history of licensing data from that organization, and it's all in a repository ready to be looked at. It doesn't stop there. We've also got our statewide all-payer claims database within the state of Wisconsin that covers about 4 million, over 4 million lives. And there we get not only the hospital claims, but also the doctor visit claims, chiro visit claims, and all of those other ancillary professional claims that are not part of the hospital association. There we're getting about 100 million claims every single semi-annual period. And so we've got the raw ingredients in terms of this raw claims data. Importantly for the Alliance, we also control the contracted rates. We have insight not only to what's happened over time with our contracts, what the contract says today, but how those will change over time and what is coming online soon. So not just an assessment based on claims data of what happened, but we can also model what will happen using this claims data under different contracted rates. Finally, as Melina called out, the new federal legislation is raising the curtain on some of the hospital price transparency. Starting in, I believe, 2021, hospitals are required to disclose not only their charge masters, but also their negotiated rate for every service that they provide for everyone that contracts with them, so including the Alliance. And so we've been able to leverage this data, look at over 100 hospitals of data to see how the Alliance compares. Those are some of the raw ingredients, but those ingredients don't mean much unless you have tools that can utilize them and make intelligence out of those data. So we have our own claims repricing, operational repricing system that we can build and utilize the source code for to build new tools to model what would happen using our operational claims repricing under other network configurations. We also have a history of development on cost estimation tools to understand not just what the costs are of specific CPT codes, but entire outpatient days of coverage that are inclusive of all of the care that the patient would see that day, including all of those ancillary providers. Finally, we recognize that, well, I guess not finally, but we recognize that there's another value in comparing not just what discounts are. We need to look at comparisons of resource use and have a benchmark to compare against. That's where we can use percentage of Medicare and relative value units to better inform, are we getting good value for what we're paying for the healthcare? And finally, I did want to call out, we licensed the Johns Hopkins Adjusted Clinical Grouper, or ACG. This is one of the preeminent risk adjustment tools that there are in medical claims data, where we can identify patient illness burden and verify the truth to the statements that the providers often give us, which are our patients are sicker and you need to compensate us because we're dealing with sicker patients. It not only does that, its primary role is a risk adjustment tool, but there are a bevy of other tools within that tool set that Johns Hopkins produces. Things like emergency visit classifications, patient conditions, and looking forward to predictive analytics towards predictions of what will happen to individual patients in the future on a probabilistic model. Those are the raw ingredients and the tools. Then the question is, what can we do with these ingredients and tools? How can we add relevancy to you all as employers. The first is to identify what is the opportunity. And some of this may be old news to some of you, but it's just shocking every time I look at it. And it's observations from data and the variability in prices. And we're going to look at hospitals to start. And I wanted to start with a very simple analogy of cost variability. When I put together these slides a little while ago, gas prices were on average within Wisconsin about $4.19. And the range, according to AAA throughout the state, was $3.96 to $4.33. Now, if someone was charging $3.50 for gas prices, there would be a line around the block in order to get that low priced gas. If someone was charging $4.50, someone would say it's price gouging. So we can compute a measure of variability based on gas prices, just a very simplistic measure that doesn't get into all sorts of fancy analysis, but the high minus the low divided by the average. So there's about a 40-cent range there divided by the average. That's an 8.8% variability. The higher the number, the more wild the variation. And so we can look at this with our hospital prices. And at the spring symposium, Chris Whaley, helped identify what hospital prices were as a percentage of Medicare. In the state of Wisconsin, the average was about 307% of Medicare. We can look at all of our own hospital data and our contracted rates and our historical claims data to compute what a percentage of Medicare is at all of our acute care hospitals. That is excluding those critical access hospitals where they're the only hospital in the area and they provide a community service. We're looking at acute care hospitals, and here is the spread where every blue bar reflects a hospital that the Alliance is contracted with, where we have enough volume of data to see with real world claims what the percentage of Medicare is for all of those services. And you can see if we use our same cost variability metric, first I'll point out where the RAND average is. If we use our same cost variability network, we're ranging from 167% of Medicare all the way to 425% of Medicare across our network. That variability is dramatic. That's more than 11 times what the cost variability of gas is. It is significant. So there's huge opportunity at the hospital level. The question is then, what does the Alliance do for you? How can we help? One of the ways that we can help is we have identified there are providers and hospitals that were willing to negotiate better rates in order for the promise of more steerage by incenting patients to utilize their hospitals and their systems. And that's where the Premier Network comes in. The Premier Network is something where we've identified the orange bars that circle around this around these hospital systems are all Premier Network hospitals, but these are the comprehensive network rates. We recognize that by negotiating with them the promise of more steerage and the promise of benefit plan design that incents their use, we've been able to shift from higher costs now to lower costs. Those orange bars that are there now are what the Premier Network rates are for the exact same hospitals. So we've moved from very high costs for percentage of Medicare to much lower costs. So that's one thing that we can do. The variability does not stop there. The variability only gets more dramatic when we look at things like steerable services. Again, we'll use our gas price metric as our starting point, and we want to look at a very simple service, a lower joint MRI, a MRI of like a knee or an ankle that you would get if you needed an ACL surgery or something like, or needed to diagnose an ACL issue. And we want to look again at all the providers in our network that provide this service based on our historical data to see what the price variability is. And every time I look at this, it's just shocking. The variability for just a lower joint MRI varies from $407 to $4,200 for in-network services. That variability is extreme. And if you can get an MRI for $3,000 in a hospital outpatient department, but they cost $400 if you're able to navigate the healthcare system in order to get the service at a lower priced location, there's huge savings opportunities. And I will point out that this metric that we've computed, which is 217% for the lower joint MRI, which is, I don't know, 25-fold difference than our gas price variability. When we look at the totality of the Alliance, what we've deemed the Alliance shoppable service, every one of those shoppable services shows a similar behavior. It's not restricted to lower joint MRIs. It is, all of these metrics have more than an 8-fold variation in gas prices. And so the other thing that we can recognize is we can look at attributes of these services, and we can look to see, are there places, are there attributes of these locations, if we're not guiding to specific locations, that are consistently lower priced. And what I've done on the graph here is I've pointed out the items in orange are all freestanding imaging centers. And so if the only thing that you pick up is that site of service is really important, and if things can be done out of a hospital outpatient department and be done at another location, that is moving you down this ramp of this cost curve to lower cost. And the other thing that I want to point out is that this is not a uniquely Alliance problem. It's not some artifact of how we've chosen to contract. There has been study after study that for commercial payers, this cost variability for these types of services that are imminently steerable provides wild variation. The chart here is from, I believe, a 2015 study from Zach Cooper at Yale, who looked not across an entire network, but just within a region in Philadelphia at a specific healthcare plan. And they showed the exact same variation for the exact same type of service. So it's not, it is, an opportunity to be had for, every commercial type of plan. So that's the opportunity that's in front of us, and it's huge. It's more dramatic than any, other market that is out there. And so then the question becomes, what pieces can we utilize in order to, how can we best utilize this cost variation and provide tools for employers to utilize the best, the best setup best setup that the Alliance can help provide. The first is the Premier Network, and I mentioned it before when we looked at that cost variation. I do want to provide that it's not a exclusive arrangement, and it's not to the detriment of all the other providers. All of the rest of the Alliance Comprehensive Network still wraps around the preferred providers, and it allows for the flexibility, still allows for the flexibility of choice while harnessing those lower rates for those premier providers. So that's a significant opportunity. As I called out at the very beginning with that network map, we also have within our contracts the ability to, for specific services, to incent and put those services for specific providers at a tier above even the Premier Network. And so that's where we can provide listings of on-site clinics or Novo or other situations that are at a tier above even the Premier Network because of our philosophy that no one provider is the best. Finally, I'm not, we're not going to go through this in any detail, but I did want to call out, here is a listing of all of the 55 steerable procedures that we have, and in parentheses are the numbers of different types of variants of those procedures that we look at in order to inform a fair apples to apples comparison between providers for those types of services. So there is a huge amount of work that has gone into rolling up, specific services into fair and comparable services, and to try and boil them down and make them actionable for you all as employers. So huge opportunity there. Then the question becomes, how do we make this data relevant to you all? Like, it's one thing to have this abstract concept, but we recognize the importance of adding relevance to the data using a specific employer's data or using your specific employer's data. Like I said, we're collecting all the claims data. It's all going into our data warehouse, and we can run all these tools and all these other opportunities that we have to run the data through our tool sets to show and add intelligence to these data to show what the impact is. This is an example for our Premier Network Savings Report, where we can absolutely demonstrate, here, this is a specific report that we had for a specific employer in our area, where we showcase what the opportunity is for a steerage to a Premier Network. And if everything successfully moves over and everyone utilizes the Premier Network, they would move on an annual period from $17 million of what they spend to closer to $14.3 million in spend. And that's significant. That's a huge chunk of money that can be leveraged if we can get patients to best utilize the network as things are set up. The other opportunity that we have is demonstrating with our data site of service opportunities. Just as we called out in our metric that we have opportunity to steer, or we have opportunity to have lower cost at sites of service that are not hospital outpatient departments, we also have opportunity to inform how employers are utilizing site of service opportunities today. So things should always be done at the lowest acuity site of service as they can. And so we provide reporting on what is typical utilization for office visits, urgent care, and ER services that looks both over time and compares to other peers in our area. Other peers, I shouldn't say in the area, other peers in the industry. And so that provider or employers can see not only how they're performing over time, but how they compare to peers in the peer group. And finally, one of the other opportunities that we have is these steerable procedures. Like we called out for the cost variability for MRIs. MRIs are a hugely utilized service. And this is a real report that we ran for a employer in our area, where you look at that first line and there's across 102 episodes of MRIs, they paid close to $350,000. That final column of $289,000 is not what they would pay, but that's the savings. That's the savings on $350,000, which almost seems too good to be true. But when you recognize that what underpins that is that cost curve that I showed earlier of $400 to $4,000, if you can design benefit plans, design benefit plans that incent the use of these low-cost providers, there is huge opportunity in front of you for things that are imminently steerable. And this is where we can provide relevance in whatever geographic region that you want to assign, and identify specific providers by name. So then the question is, what actions can you as an employer take when you are going through and designing a benefit plan design? And the first is to set up a tiered structure in which you are providing incentives where at the tier 1 or tier 0, there is no cost to the patient. If we can utilize those low cost services, there's so much savings opportunity there that even if there's no patient out of pocket cost, there's still savings to be had. And that is where we can identify specific services, and we can identify specific providers that offer those types of services to be put in a tier above, anything else. The next tier down, you can set up services that would be in the set of preferred providers, either through the Premier Network or otherwise. Then you have the comprehensive network that goes beyond that, that's still accessing all of the alliance negotiated rates. And finally, you've got a benefit plan design that disincents out of network care. So that's a structure that can be implemented, and we can provide guidance today on how to structure that to best leverage the cost variabilities that are inherent in the system. And we blitzed through this, but this is the last slide that I have, and I want to spend a little bit of time on it to identify that we have a growing set of tools and expertise that has taken some of the data that we've been able to collect over the course of several, years and decades in order to make them actionable. With federal legislation, we are beginning to report all of our specific costs for all of the services that we provide, and make those available to all of our TPAs and to all innovators. That's part of federal legislation, and that came online July 1st, so just in the last week or so, or I'm sorry, time flies, the last month or so. And so that's transparency that we're adding to those consumers. Our smarter health analysis, which has been the focus of this discussion of where we get our data and how we utilize our data in order to inform benefit plan design that incents steerage, is focused on employers and on those groups that are informing what the benefit design looks like. But our work doesn't stop there. We also have, I didn't go through it today. I didn't think that there would be time to go through it, but we also have a Smarter Care Advisor, which is something that is live on our website today. That Smarter Care Advisor is something that patients can go and look up many of those steerable procedures, and they can see a scoring for all the providers in a geographic region of low, medium, and high cost. And so patients have tools available at their fingertips as well. And finally, as a cooperative of over 300 employers, we have over 100 different employers utilizing some form of steerage today, whether it be through the Premier Network or specific tiered designs. One of our obligations is continue to track the success and the lessons learned of those groups that have been very successful in educating their patients and allowing for those steerages to happen, and to best utilize this broad comprehensive network that we have in order to sort of pinpoint the areas of care that they can utilize and get better cost savings out of. So those are that was a quick whirlwind tour of some of the tools that we have available, some of the actions that we can help guide for you guys as employers, and where we're headed in the future as we continue to harness all of those tools available in order to make actionable insights for you as an employer. With that, I believe I will turn my camera off and turn it back to Melina to introduce our panel, and I'll wait for Melina here for one.
Before you leave, so a couple of points of clarification, if you don't mind, and a question that we have from the audience that they wrote into us before even the webinar began. So we've chosen our shoppable procedures very specifically because we look not only it's a discrete event, it's something that's schedulable, but also we look at our employer data and we know that things like MRIs, imaging, radiology, ultrasounds, colonoscopies, musculoskeletal, they're all, in terms of volume, a very big spend of our employers. Do you agree with that?
Yeah, absolutely. Those are the purpose of the choice of our steerable procedures are things where we expect that the patient can leave their home system, go get this acute service, whether it be radiology, musculoskeletal, or whatever, and come back to their home system without a disruption of care. And so that's what has driven a lot of the decision making on our steerable procedures, in addition to them being enormous areas of spend within our providers or within our employer book of business.
Right. So the other question that we got, well, this was a clarification for me, but the question we got had to do with the Smarter Care Advisor, because there we don't actually show the actual dollar amounts. And the question is, where and how can I get an estimate? Of course, the answer is please call us, please call your account executive. What is the future for the Smarter Care Advisor?
Yeah, it's a good question, and we will continue to review its use, particularly as starting in 1/1/23, there are requirements to make other tools available. The employers are required to make other tools available in terms of cost estimates. We purposely chose to simplify the Smarter Care Advisor to this high, medium, and low because what underpins a lot of those cost estimates is there can be variation in what the experienced costs are based on the type of MRI that's received. We know that an MRI service at a particular provider will be low regardless of what service you get compared to another, but we didn't want the patients to need to do the work to identify what is my specific CPT that I'm getting. Sometimes that's not known until the patient presents for care, like for example in a colonoscopy. And in addition, we are most interested in not providing specific dollar amounts that someone can go back and say, well, that you said it was going to be $273 as this blended rate, and it was $285. What gives? I want my $12. That's not the intent. We are trying to move from those areas of high cost to areas of low cost, without specific requirements on, am I right down to the penny? And absolutely, we do have folks that are doing cost estimates for specific CPTs, if those are known, to provide more direct guidance if a service is known, if a patient is very interested.
So another question we got in is, do public employers use your tools and network, or is it mostly private employers? And of course, the answer is we have a large book of business with public employers. And actually, Sarah Hames on our panel next will talk more about public employers. But we use both the network and the tool for both private and public employers. Right? You agree with that, Ryan?
Yeah, absolutely. We have a broad range of employers in our network, both public and private, and this data and these tools are not limited in any way, shape, or form to specific types of employers. We're able to look at it for all sizes of employers, and we've got tools to run things for even very small employers where they might not have a ton of data, but they want intelligence on, like, it may not be the best to run historical data for me because I've only got 27 lives in my group, but I still want to know where to send patients. And we've got tools to do that as well.
So do me one more favor. You have 2 minutes to talk to us about our future on quality ratings, please.
Geez, you're putting me on the spot. Yeah, so quality, there is, quality is certainly important, but there are services. If you look at the continuum of both steerable services and the stuff that's not in steerable services, you'll notice that there's a whole host of things that are not in our steerable services where we're not trying to guide. Things like cancer care, things like, end-stage renal disease, other things that are very complex. We are not trying to do anything with steerage there because we recognize how important quality is in those domains. There are other areas where we are much closer to a commodity. Those services are, for instance, drug pricing would be an area where it's a commodity. If you get it out of a package, it doesn't matter where that package comes from, it's closer to a commodity. And there the quality may not vary, or quality may not matter so much. There's an area in the middle of those, things like knee replacements, things like gallbladder surgeries or other things that are within our steerable procedures right now, but quality may be more and more important. We are working with consultants, both a clinical advisor, that's a doctor, a primary care doctor, and with consultants that have done work on the quality axis for Consumer Reports and a host of other organizations in order to inform how we can leverage quality ratings that are out there to better blend with the cost information that we already have for those services where quality is deemed a little bit more important than a commodity. So there's more to come there, and we're continuing to work on that axis to provide relevancy to make best arm you guys in order to make whatever decisions you want to make for benefit plan design.
You all can tell we had an audio glitch. I'm so sorry. Ryan, thank you. I'm so sorry I put you on the spot. We absolutely appreciate you sharing your insights today. Please, to everybody who's participating, if you need further assistance, not only many employers actually have access to Ryan, but also you can reach out to your account executive here at the Alliance for further assistance. So Ryan has agreed to stay with us until the end of today's webinar to answer any other questions, of course, time permitting. So think of your questions and type them into the chat box. I want to switch gears and I want to turn our focus toward our employer and consultant panel. So folks, team, if you would like to come on, please. I'd like to take this time to introduce our panel. So I have here with me Sarah Hames, first and foremost. No, you're my mentor, Sarah, so I always go there to you first. Sarah is a principal with NBS Advisors. She has more than 30 years of experience in employee benefits consulting. She concentrates on finding innovative, non-traditional healthcare strategies that are emerging around the country in order to develop and implement techniques to benefit her clients. She has dedicated her practice to helping interested employers disrupt and transform traditional healthcare into sustainable delivery models. And as the audience could tell, Sarah is very generous with her time in mentoring people like me, but also younger advisors in Wisconsin. So for that, thank you, Sarah. Next is Drew Leatherberry, who is the founder of Avergent, a Wisconsin-based benefits and care advisement firm serving employers since 2019. For over a decade as an employee benefits advisor, Drew has started and spearheaded agencies that lead innovative approaches to managing healthcare costs. He's been recognized regionally and nationally as a voice for transformation in the healthcare benefits arena, and also Drew is a Health Rosetta advisor. So welcome, Drew, and thank you. Drew is here with Candice Meronk. I asked her before how she pronounces her name. Always have difficulties with names. Candice Meronk from Team Sherrill Companies. Welcome, Candice. She's been with Team Sherrill since 2000 and has been in human resources senior management for over 30 years. In the last 5 years, she has been spearheading efforts for Team Sherrill to control costs of healthcare and to really win. It's a win-win for both Team Sherrill and for the employees of Team Sherrill. We also have Dan Ladwick from Breakpush Brothers, and Dan and I have been working together for 5 years. He's a member of the Alliance. He's the Director of Benefits and Safety at Breakpush. He has developed Breakpush Brothers Centers of Excellence program, which includes steerage and international prescription benefits, for which he actually received a Health Transformation Award from the Alliance in 2018. And then the following year, we traveled to the National Alliance National Conference, and he was awarded the Employer Purchaser Excellence Award in recognition of innovation in healthcare strategy. It is very noteworthy to say that previous winners of this award included Walmart, Disney, and companies, large companies like that. Welcome, Dan. So last but certainly not least, a great partner for the Alliance and for our employers, I would like to welcome Jeremy Ott from WPS. Jeremy joined WPS in 2002 and has been in his current role as the Vice President of Health Insurance Economics since March of 2016. In his current role, he oversees a cross-functional team that is focused on developing and implementing innovative strategies to lower the cost of healthcare and improve the member experience. His team delivers quality health and ancillary insurance to thousands of customers of WPS, but also to WPS health plan members, the WPS employees and their families. Prior to his current role, Jeremy held positions in underwriting and sales, and that gives him a very unique perspective on healthcare and healthcare economics. So thank you all for being here today. We're excited to get the employer and consultant advisor perspectives on what methods you're using to better understand data. We'd also like to understand how you're using that knowledge to make strategic planning decisions for designing benefit packages. So I am going to start with our first question. We've had a lot of questions from our audience before the webinar started and now that we've started talking. So Candice, I'm going to address my first question to you. How have you used data to influence your C-suite, your leadership, and what has worked and what hasn't worked?
Thank you, Melina. For me, it was actually easy to influence the C-suite, but having the data available really demonstrated where we are and where we could go. Working very closely with our benefits advisor was very important. Without the data, it's kind of like going on a road trip without using a GPS. So it was very important for us to know our plan, which not to make a lot of assumptions, to really get inside of that data and understand our audience of insureds. So, I mean, just to have the data available was just a valuable way for us to say, here's where we are, here's where we need to make improvements so we could get on the right road.
Thank you, Candice. One more question for you, if I may. When I introduced you, I said that you've held senior management HR positions for a long time. And so what piece of advice would you give to a newer HR administrator who's just now starting to dig into their data?
That's an interesting question, because I will admit that I used to be very bored with healthcare data. In all of the years in HR, you kind of just accepted what was in front of you and you kind of followed the lead of whoever. But about 5 years ago, I knew that along with our CEOs, we really wanted to attack healthcare. We wanted it to be win-win, not just for Team Cheryl's bottom line, but also for our associates, for their families. The advice that I would give is make sure that you're aligned with the right broker, somebody who works with you, not just for you. Never be afraid to ask questions. And even if you've asked a question, ask it again. There are so many resources that HR professionals can immerse themselves to learn, whether it's the Alliance website. You have so much valuable information out there. Health Rosetta, you can learn from other HR people. You can attend the various healthcare meetings that are being put on. There's so many ways that you can learn. I'm typically a very low detail person, but in the last 5 years, being able to learn all of this and have the data, it's turned me from being bored to being passionate because of knowing the end result that can come with redesigning a health plan so that it is win-win. So go out there and ask questions.
Yes, thank you very much. And actually, not being fearful to ask questions, I'm going to turn over to Drew. And Drew Leatherberry is Team Cheryl's advisor. So Drew, a couple questions for you. How has having access to data in real time changed employee actions and options? You have a lot of experience on looking at real-time data and helping guide employee actions and options. Can you talk to us a little bit about that?
Yeah, absolutely, Melina. And I can attest to Candice's questions. They're fantastic, and they've led to a lot of great actions for their associates. Data in real time is really a challenge in healthcare, because as we know, much of healthcare happens and we're responding to it. But to give you an example, setting up communication lines with one of the plan resources, utilization management, allows you to coordinate resources around the plan to be able to intercept some of those shoppable procedures that Ryan talked about before. Giving an example, an MRI being done inside of a hospital facility, we know is just going to cost more than when it's done at a freestanding facility. If you have the appropriate coordination set up behind the scenes, you can identify those opportunities when they come through for pre-certification of that procedure. Taking from that pre-certification notification, if you have the tools and the benefit design in place, you can actually intercept it, and intercept in a very positive way to assist the member And moreover, as Ryan talked about before, and this really goes to the heart of what Emergent tries to do. We go against the grain. One of the things that we've identified is that even when diagnostic tests like MRIs come through, those are just simply data points that lead to a bigger story. And so one of the things that we don't assume is that those MRIs are really appropriate in the first place. So a lot of times what we're doing with data is we're also understanding who's ordering the MRI, why are they ordering it, and what needs to be done both leading into that MRI and coming out of that MRI. Because what we've started to learn is that in healthcare and in health plans, many of the rules and the benefit design are set up around what is generally accepted, which doesn't always take into account what is specific to that patient. Things like social determinants of health, things like comorbidities. And so all of that information needs to be understood in order to provide the best guidance and outcome in real time.
So just to follow up a little bit more on that, I know you do a lot of work with condition management data as well. Can you explain how having access to condition management data has led to cost savings, improved outcomes? You and I have talked about, you know, even small examples like maintenance medications for diabetes and chronic disease.
Yeah, this is one of my personal passions. Having been in the broker community for a long time and providing data reporting to employers, there was a point a few years ago where I recognized that there was a difference between providing a report and informing, and providing a report and being able to give actionable information, resources, tools. Type 2 diabetes is a great example. If we identify that there's a cohort population inside of a group, we need to be able to then take it to the next step, not just providing tools and resources to make sure that maintaining the condition is not only affordable and accessible, and that people are in good relationships with providers and clinics and facilities that want to help them manage it, but also to take it to the level of saying what programs exist in the market that can and will reverse a condition like type 2 diabetes. We've seen now with a specific pilot test that there are programs out in the national market that will come in at a very affordable price and be able to engage with a patient and reverse a condition like type 2 diabetes to the point where people are off insulin, blood pressure is lowered, weight goes down. And so there's a lot of things that can be done, not just to identify individuals with conditions and make sure that they're managing that condition, but also to take it to the step where we reverse and go towards better health.
Thank you very much. Jeremy, can I come now to you? So Jeremy represents WPS. WPS is not only a large employer in Madison, an employer owner of the Alliance, but also an insurance company and a TPA. So as a TPA, you have access to a lot of client data. Is there anything you learned from that data that you've implemented as an employer now, or would you recommend to employers to implement?
Yeah, we've obviously been very involved in engaging with the Alliance on different opportunities to be creative and be innovative and create programs that will benefit our own employees. And we worked really closely with the Alliance to implement a lot of the things that Ryan hit on earlier as part of that. But really our focus was on creating incentives for our employees and our members to be incentivized to making high value decisions. And so one of the first things we did was partner with the Alliance to implement their Premier Network, in which case we lowered the out-of-pocket costs for our employees for those members that wanted to go to a Premier provider and get the high-value care at those different providers. But we didn't just stop there. We also took it to the next level and implemented an additional tier, which we refer to as our Tier 0 level of benefits, where we wanted to reward members that made truly high value decisions, where we would waive their out of pocket entirely for making those high value decisions. And those are on a number of different services, ranging from high value imaging and you know, a lot of musculoskeletal services, a lot of the selective elective surgeries that members could have throughout the year. And I'll just give a personal example. I think this example's been used a couple of times. As luck would have it, to start the year, I tore my meniscus right as the calendar turned. So right as my deductible was reset, right as my out-of-pocket was reset. And I knew when I went into my primary care physician, the likelihood of me needing to get an MRI was going to be high in that situation. And of course, when I went in, that was the first thing he suggested, was to go get an MRI. I knew at that point I had a choice. I could have gone down the hall, had the MRI, had it been really convenient, but I also know that that MRI was going to cost me somewhere between $2,500 and $2,800. Most of that coming out of my own out-of-pocket, because I just said reset the deductible, and also was going to cost my employer. Or else I could take a step back and look for a high-value provider outside of the system, in which cost me nothing out of my pocket and also save the employer significant funds from that perspective as well. So that's just kind of an example that we've used in order to help incentivize members to view high value care. One of the other things we implemented and we thought was very important was also provide incentives for members to seek virtual care through our vendor Teladoc. One of the big things through the pandemic has been the behavioral health shortage and the concerns around behavioral health. So that's one of the main drivers of why we did what we did, was where our members can have access to behavioral health through Teladoc at no cost share to those members and get the care that they need at a convenient and low cost to help take some of that burden of some of those things as well. And then in addition to some of those things, we did also, and not only make some of the care free, we also have built in certain financial cash incentives as well, because the savings are so drastic in a number of these services that you can really save enough that not only can you waive the out-of-pockets for your members, but also provide cash incentives and still be better off as an employer from a bottom line perspective. But implementing the incentives isn't by itself, in my opinion, isn't enough. You need to give your members the tools to be successful. So we entered into a strategic partner with a great company called Aletheus, which they serve as our care navigation for our employees. So if somebody in the situation like I am and they need an MRI, they have a simple number that they can call and reach out to and have a care navigator that can help navigate them through the very complex healthcare system that we have. Because you know, the systems are really good at trying to keep you contained within their systems, and it's not easy to get the information and the data you need to make some of those informed decisions. And so by using that care navigators, they can really help you. But there's a lot of tools. Aletheus is just one. We also partner with a tool called Focus Health, which is more of a digital platform that helps you identify preferred providers that you can utilize. As part of that, it's more of a digital online through a portal experience, if that's the type of more better for your population, your experience. And then just the last thing quickly, the other thing we did was we invested heavily in educating our members in this program. I cannot emphasize enough that healthcare is complex, and the concepts that we're talking about with data analytics is very complex. And you can't assume that members are going to comprehend everything based on one meeting and open enrollment. It has to be multiple communications throughout the year to keep this in front of your members and get them exposed to it, because you know, nobody necessarily knows when they're going to need the care navigator or the steerage as part of that until it comes up. And so keeping it front of mind is important. And so just to kind of give an example of the value that WPS has seen from this, we set a target for ourselves at the beginning of this year by implementing these. We wanted to save what we thought was a very modest savings of about $1.3 million in reduced healthcare spend for the year. I'm very excited. Just last week, I got the first report through the first half of the year through June with 1 month of run out. So it's even probably a little bit light from that perspective. And we've already seen savings just shy of $900,000 for the year. And so we anticipate, just by doing what I'm going to say is like the first step in the process of steering to high value, we've already seen significant savings. And I think these are things that can help a lot of employers as we go forward.
Oh, that is absolutely fantastic. You were saving this as a little present for me, right? Because I didn't know I knew that we were working to get the numbers, but I didn't know the numbers. So a couple more questions for you, Jeremy. And actually, one of our participants, as you started talking, made the comment and a question and maybe Jennifer can show me that question because I read it really quickly. So this employer is self-insured and they use a TPA. And at a meeting recently, they weren't willing, the TPA was not willing to discuss detailed claim info. But if we were without a TPA, we would get, but if they were self-insured without a TPA, would get that information anyway. I don't know that I understand that question very well, but as a TPA, because you work with employers as a TPA, we all believe, everybody here in this virtual room, right? We believe that the data belongs to the employer. Can you just touch on that just for a second?
Yeah, I would say, in my opinion, at least in the WPS perspective, with our partnership with Oxyan, my belief is if you're self-funded, you own the data. And if you're not working with a TPA that's willing to share the data, you know, that could be a challenge. And you know, if you work with WPS or if you utilize the Alliance, we're both very transparent. And if you're not able to get access to the data, it's really hard to do some of the things that we're talking about here as part of this the strategy piece. And so whether it's your TPA or working with a broker that can get you access to the information or the data, I think those are vital if you're going to be successful in trying to implement some of the things we're talking about here today.
Yeah, absolutely. So please give us a call because you should have access to your data. If you're self-funded, if you're fully insured, that may be a different, perspective, a different issue. And if you're large enough, we think here in this room, we think you should be self-funded. Jeremy, one more question. Data analysis can seem overwhelming. I mean, your title says insurance and healthcare economics. That's a huge title, right? So you're a data geek like many of us here in this call. Where do you start? What steps can you take? What's the good and the bad? Can you share some lessons learned with us?
Yeah, I think a good place to start for any employer is the same place that we started when we started going down this path a long time ago. And I think you need to start by defining what high value care means to you, because I think it means different things to different employers. You know, to some people it may be as simple as just cost and trying to find the lowest cost. I think that's a little short-sighted just looking at cost. I think at a minimum, I think where most people are at least some kind of a combination of cost and quality data and looking at them together and figuring out how those work together to find high value care. But then I think, you know, as we look at it, we a lot of times try to bring in a third variable, which makes it, the more variables you bring in, the more complicated the analysis gets. But I think it plays to some of the stuff that Drew was talking about in regards to, we usually look at value. We try to identify it as a combination of cost, quality, and appropriateness. Because you can have services at a high quality, low cost provider, but if it wasn't appropriate to have that procedure to begin with, then it doesn't matter what the discount is that you got, or if it was a great low cost, because it shouldn't happen to begin with. So, you know, depending on what you're trying to accomplish, I think that's the first thing in figuring out what it means to you. And depending on what you're trying to accomplish may help you answer that question. You know, some people might be looking to do this just to help their members find high value care. That's great. That's a great initiative to do. However, I think most of us are in a little bit of a different boat. It's not only helping our members find high value care, but it's also trying to bend the cost curve, right? And depending on how far and how steep you need to bend that cost curve may help determine on how far you need to take that and how you look at it. But in regards to what steps, I think the first thing I'd recommend is you need to come up with a plan and really sit down and come up with, and hopefully you have a good broker you're working with that can help you with this, but you know, create your guiding principles when you start to dig into the data and what you want to do at it, and focus on strategic targets. Because I'm going to tell you, if you go into this without guiding principles or strategic targets, there's so much data out there, you can get lost and just you'd be spinning your wheels on trying to come up with something that may or may not be there. But I think a lot of it comes back to the cost piece. You know, you need to be able to understand your cost, what the drivers are, the variations, a lot of stuff that Ryan talked about today, this morning. He was right on with the variation and the different things that come in there. And then after you've got an understanding of the cost component, then it's how do you layer in some of the quality metrics and do that. And in regards to some of the good and the bad that we've learned through this process, I guess I'll start with the bad. And the bad is, and this isn't anything new in our business, but it's very interesting if you were to graph cost and quality on an X and Y axis. You put cost on an X axis and quality on a Y axis. In our business, and every study shows the same thing, our data shows the same thing. there is virtually no correlation between cost and quality in healthcare. It's almost zero, which is so unusual. You know, if I go to Best Buy and look at TVs, and I'm looking at one that costs $300 and one that costs $2,000, as a consumer, I'm led to believe that if I'm buying a $2,000 TV, it's of a higher quality than a $300 TV. In healthcare, that is not the case, and we see it over and over again. Now, the inverse of that is the good part of it. Because there is no direct correlation between cost and quality, it also provides a lot of opportunity. If we're able to get members to seek high value care, high quality, low cost care, there is a lot to be saved, not only from a cost perspective, but a better experience and a lot of the drivers that come out of that. So, you know, if that's what I'm going to take out of the good, there is a ton of opportunity out there for employers.
Thank you very much. That was fantastic. Thank you. Dan, can I turn to you? Now, I know you have saved over the years a lot of money to your organization by not only your strategic planning, but as part of your strategic planning, using data. Can you talk to us how has using data saved your organization both time and money?
Yes, thank you. The first thing is, you know, for all those that have moved from a fully insured plan to being self-insured, you recognize that now you've got an opportunity to dig a little bit deeper into your own personal data, instead of looking at these more broad topics and data. You can drill into it. And so what we started doing is looking at where our opportunities were. You know, is it in advanced imaging, or is it in orthopedic procedures? So are you doing 2 MRIs a year, or are you doing 50 MRIs a year? How many joint replacements are you doing in a year? And is that fairly consistent? And once you know that, you can kind of pinpoint, okay, here are the areas that we can attack. If we want to attack MRIs, for instance, we're going to try and find a provider that's going to give us the best deal on that MRI. And with that, we have to know, not only are we doing, you know, 50 MRIs in a year, what are we paying for those MRIs? Is our average MRI cost $1,000, or is it $4,000? For us, our average MRI was getting almost to $4,000 due to where people were getting their MRIs. So we went out and looked and said, okay, what providers can we get us the best deal? And then we were able to find ones that said, okay, we can do an MRI for under $1,000. $600 is a great deal for an MRI, and shows that price difference. And you could say, okay, well, at that point, it's easy to say we're saving between $2,000 and $3,000 for that MRI. So with that, we identified that as a particular partnership. From there, we said, okay, what happens next after that MRI? Usually that orthopedic procedure. And how many orthopedic procedures are we having per year? And now do we need to find that partner that's going to help us with that orthopedic procedure? So with that, we're able to identify, you know, basically how big of a problem do we have, and then how big of a potential do we have with that. So that's how we're able to use that to determine those two things and try and drive change.
Yeah, thanks. And I also know that you had some surprises when you started analyzing your data. How did you change your plan design because of what you saw in the data?
And so the first thing, it was surprise. There's a lot of things that'll surprise you if you've never looked at healthcare data. One of the big things is the lack of consistency in data. You have to look at it from a multiple different sources, and then come up with the one that you feel is the most credible, and start using that data. If somebody tells you you're spending on average $250 for an MRI, that there's something wrong with those numbers. So you have to dig a little bit deeper into it and find out what is it that they've missed. And often with that, you're going to find that what they're missing is they're attacking one part of that particular episode of care. Are they just looking at the cost of the read? Are they looking at the facility cost? What are they missing when they're giving that type of data? And if you could get to that, then you'll get to a full picture. of what that particular procedures cost. And honestly, the biggest surprises really come down to what has already been shared by Ryan earlier, is that incredible price difference between the low and the high. And with that, looking and say, okay, well, if we can save $20,000 on a joint replacement, you know, how do we get people to go there? It's not good enough to just say, hey, go here because you're going to save the plan money, and in the future it's going to save premium dollars. Most members care about, well, what is it saving me today? And why would I drive this way when I've got a provider here that's right next to me that I can utilize? So we knew that we had to somehow financially incent people to go to these providers that might be an hour or more away, and what we're going to do for that. And some of that is through plan design, and some of it is through financial incentives. And we've used a combination of both on that. And one thing, a lot of people, another thing that everybody who's running a plan should do is, when you think, well, I'm going to up the deductible or up co-insurance or whatever it may be to drive people to make better healthcare decisions, you need to actually run the numbers on that. And you may find that a person is going to hit their max out of pocket regardless of if it's a $27,000 knee replacement or a $53,000 knee replacement. That member is going to hit their max out of pocket. So is your plan design at the way it is currently going to save your member that money and give that financial incentive to say, hey, we could save over $20,000 if you go to provider A over here? So you have to run the numbers on a variety of different cost levels to determine, is your plan serious? So what we did is we looked and said, okay, we're going to make certain procedures over a certain dollar point with a certain provider. We're going to have that at no cost to really try to drive steerage for that. For some of our lower cost procedures, the plan actually did do a lot to drive that change. If you've got more of a typical plan with a $1,500 deductible, you're going to save a lot of money going to a $600 MRI versus a $3,000 MRI. The plan already does that. But what we did is we layered on top of that a financial cash incentive to say, hey, go here, and we're going to give you this cash incentive through payroll to drive you to go to that. That's evolved, and now in 2023, we're completely revamping our design and going to a 4-tier model, very similar to what you saw earlier with Ryan's presentation, and a very low cost share associated with a lot of these tier 1 procedures, because it's one of those to say, yeah, there's not a whole lot of cost share for the member to get this expensive procedure, but if they go elsewhere, it's going to cost us tens of thousands of dollars more. You know, the example I use, $20,000 for a joint replacement. If we can save that, it makes sense to make the cost almost nothing for the member. The same thing, spinal fusions, you know, then you can be looking at $50,000 of savings. It makes sense to really pull out all the stops, because we want to make sure that they're going to the best value that we can get for employees. So we've completely revamped our plan design to make sure that we're going to do everything we can to steer to ones that we find to be the best value.
Yeah, thanks for that, Dan. 5 years ago, when I joined the Alliance, our current vice chairman of the board, he was then becoming a client, becoming an employer, owner of the Alliance, said to me, don't underestimate free healthcare. And that's how we started working towards data analytics. And now we are at a place where we're talking about tier 0, no cost to employees and their families for certain services at certain sites of services, because the savings to the employers are enormous. They're tremendous. That variability that Ryan was showing before, 218% variability for a specific procedure, that's amazing. Sarah, I want to turn to you, and I am going to go to a question that we got earlier, and I asked that of Ryan. But because you work with a lot of public accounts, one of the earlier questions we got was, you know, can public accounts use this data? Can they use the Alliance? So my question for you, and if you can tie it to public accounts, I would appreciate it, is what criteria do you use for decision making when setting up a steerage program?
Well, that all rests on great data, right? You have to have the good data to make that decision. And before I go too far on that, I just want to reflect a little bit. 5 years ago, when I started down this road of helping a public employer find a plan, a different model where we're going to steer to high value like we've all been talking about all morning, I felt like I was on an island, that we were the only ones having these discussions. So it is very refreshing and inspiring to be on a panel like this with so many employers and other advisors who really get it and are really pursuing this. And of course, the Alliance, you've done so much to help in this area, because that's really probably the biggest frustration if you're not working with a partner like the Alliance. How do you get this data? Your traditional carriers don't want to give it to you that way. I was in, ironically, a meeting with a very large public sector account, and it was with United Healthcare, and we spent hours drilling into data, and they showed us a lot of interesting, comparisons, et cetera. And I said, so can you tell us how much we pay for a knee replacement, at Aurora, at Ascension, at, Pro Health? No, we don't look at data that way. And it's just very frustrating when you can't get at that same data that we need to make these powerful decisions. So the criteria is just simply, if we can't get the data, we can certainly rely on those generalities that Ryan referred to, right? We know that freestanding facilities are likely going to be much less expensive. Fortunately, a lot of the freestanding facilities, and now with the new transparency rules, we can go online and dig around and find out what they charge, for things. Maybe not specific to the network we're using if it's not the Alliance, but we can get some pretty good data. The other tidbit of information is look at their cash prices. And that will give you a fairly good idea too of what their non-cash prices look like. So again, really good information, but you have to have those good partners that understand this and can help you look for it and are willing to put the work into it. As we all can attest to, this is not easy necessarily. It is time consuming. We're asking a lot of questions, a lot of whys and why nots, but as we peel back that onion even further, it becomes what I like to refer to as disgustingly fascinating, but we want to learn more. And then we want to direct our members to those good choices too, right? They don't like getting ripped off. And when you educate them that there's a difference from 400 to 4,000 in an MRI, they're going, what? I just paid 3,000 for an MRI and you're telling me I could have got it for 400? They start making different decisions and they're better off for it.
And you actually took me there, and I know you can't see the questions that I see that I get from the audience, but I just want to persist on this just for a second, because I asked Jeremy before, there is an employer online who says, my TPA does not want to share data with me. And so we got a follow-up question, and this participant is essentially saying, and I'm not going to name names of companies, of insurances or TPAs, but they would like to get their TPA to be more transparent with their data. So they're asking for help. So let me just first say that I refer to the Consolidated Appropriations Act early on. So your TPA cannot refuse you data. You cannot have gag clauses in your contracts. There is contract language that you can insert and make absolutely certain it's inserted in your contract with not only your TPA, but with your vendors. We are working with a firm that has had legal advice and has used legal representation to help us with the language. I will tell you that I'll have that language in a couple weeks. Please call me, regardless of whether you are with the Alliance or not. What we want to do at the Alliance, and what all of these folks here want to do, even if you're not their clients, we want to help. This is our mission in life, to help control the cost of healthcare and to make certain that third-party vendors are helping you be a fiduciary. So please give us a call, give me a call, find me on the website, send me an email. And then the other question that this person asked is there other TPAs who are more friendly. So if you care to know about other TPAs, you can call my colleague and partner in crime in healthcare, Jeremy, and he can help you with TPA services as well. But your fiduciary responsibility, and this is very serious because it is now the law of the land. It's always been, but the CAA has made it even more pronounced. You need to be a financial steward of your plan, so you can't do that without data. So speaking about all of that, third-party vendors, Sarah, how can they support data analysis? How do you use, TPAs, the Alliance, PBMs? I know the Alliance is not in the space of RX, but I know you have some great PBM partners that they help you there as well. Can you talk a little bit more about that, Sarah?
Sure, I'd like to address that, the TPA question. In the last couple of years, I started working very diligently with a TPA, and the amount of data that we get is just amazing compared to working, with the more traditional carriers. I mean, we're getting metrics both in terms of cost and utilization, et cetera, and amazing benchmarks. We can benchmark it to Wisconsin, to the commercial market, et cetera, and to a percent of Medicare, to Ryan's point. And we have to move away from the silly notion that a 60% discount is of value, because unless you know what that 60% results in, it is of no value. And I think the only way that we can get to a universal metric is probably as a percent of Medicare. And yes, finding that those partners is really critical and interesting. Sometimes you may find it in a broker, but I will caution you that, take a deeper dive into the data that they show you. And even in the carriers, there's some nice, flashy, colorful reports out there, but when you really dig in to find out actionable data, it's very little and incomplete. And that can go for some, reports that, brokers put forth as well. So ask those questions ahead of time. I think Candace referred to it before that, hey, I used to hate data and all this stuff, but when you start digging in and you know what you're looking for, it gets rather addicting. It really does. You might find some, I just discovered some great data from one of our clinic vendors who's able to take the claim data and combine it with the employer-sponsored clinic data and give out some great reporting. We're introducing a new program that focuses on allergies, treating allergies with drops instead of shots. It's a fantastic program. And we've got good benchmark data now to see how many people have these allergies and what this program a year down the road might do for them. Or not, I guess it could be as well, but at least we get that data to see it. In the PBM world, we are, finding out that if certain medications aren't covered, under your health plan, that you can actually get them from the manufacturer. Can be a lot of paperwork, et cetera, but it can, if you find a PBM partner who is willing to help you with that and do literally all of the paperwork for the member is completely appreciative, and the plan can save tens, hundreds of thousands of dollars, by sourcing. I call it alternative sourcing, even through international, a pharmacy in Vancouver, Canada, for example, where it's not coming from, a Thailand or a third world country. I mean, it's probably coming from the same manufacturer we'd get it from here in the States. And you can do that with the right TPA with what they call the J codes, the infusions as well. If we alternatively source them instead of getting them through a hospital where they tend to mark it up a lot, it's a huge savings. And again, give these options to the member free. It helps them to make a smarter choice, and it helps the plan with the savings and the members out of pocket. So why not?
Yeah, Sarah, I'm going to stay with you because the public purchaser that has been speaking with us through chat has one more question. And but before I get to the question, I just want to say that Sarah and I a couple weeks ago videotaped an interview about plan design and what are the components, not only plan design, the tier 0 and other such elements, but also what components are necessary for employers in general, but specifically for public accounts, for public employers to be able to implement so that they can save money. So Sarah, the very specific question, do you mind talking about the very specific plan design that you introduced to your public employers?
Which is not very different from some of the plan designs we've been talking about today. It's really starting out with a very solid, strong, independent primary care partner. And I say independent, somebody mentioned it earlier today that, once the system's got you, once you're in the system, they're going to refer within their system. And it's hard for most people to debate that with their doctor, and like Jeremy did, and say, no, I'm not going to go down the hall, I am going to go elsewhere. For some people, that's a pretty difficult conversation. And yes, Drews, I know, has built in some very nifty tools that help steer people to that right place. Hopefully all of us can get a little bit better at that. But it's starting with that strong primary care partner, and then identifying those high value providers, and then training the primary care partner to be able to refer to those high value partners. And if you make that all free, you get a willing patient who is eager to go into a clinic where they don't have to worry about cost. They know that that provider is there only to take the best care of them and doesn't have a conflict of interest in raising revenue for their organization. And in fact, they're, one of their primary goals is to save money, for the employer that they're working for, and to just give these people a big hug and treat them and get them everything that they need. And when they can refer into a high value provider and make it at no cost to the member, it's a win-win for them. But we don't want to take away choice either. And if that member wants to go somewhere else and is willing to pay for that, or maybe there's not a high value option available to them, then we certainly want to allow them to do that. This is their health care. It's very important to them. Generally, they make, really good decisions when they know about them. Communication gets a little tricky. It has to be constant. As mentioned before, it can't be just one and done at an open enrollment period. It has to be made available to them. But then there is that general education. For example, we have a public account. It's a school district who implemented a plan like this about a year ago. And some of the services are not available in their area. They may have to drive an hour and a half to get them. And somebody asked the very good question, well, by the time you get a substitute for me and you pay me $150 to drive a couple hours to get this service, how are you saving money? And thanks to the, being able to get information and good data, we said, look, a CAT scan in your area is about $2,500. If you drive an hour and a half south, it is about $350. Now, add to that your $150 incentive and the cost of a substitute teacher at about $150, and you're still saving, well over $1,000. They get it. We have smart employees. And when you show that to them, they become a much different buyer. It really is a consumeristic plan.
Thank you.
Did I answer all of that, Melina?
Yes, and please watch our video. It will be coming online, I'm certain, pretty quickly. Give us a call and watch our video, because Sarah and I'm interviewing Sarah in that video, and we go through about 15-20 minutes of a discussion on that. So thank you for that. Dan, I'm going to come back to you. Where or to whom do you go for help in understanding your data?
Number one, you.
Yes.
Two main sources for data, and that's the Alliance, and we also partner with Aletheius. Aletheius helps us, especially when we're looking at data outside of Wisconsin. The Alliance does really good inside of Wisconsin. We've got quite a few members in 3 other states outside of Wisconsin, as well as, you know, Salesforce that's national. We got to be able to capture that. So we use both the Alliance and the Alethea, and then it gives us a chance to compare different data sources and verify one versus the other, and they both are solid data sources. So it depends on what particular I'm looking for to determine which one I'm going to pick up the phone and call.
Thank you. Drew, we got a handful of questions on smaller companies, companies of smaller size. I'm going to try to do my best to kind of put them all together because I know we only have just a few minutes left. What do you recommend for smaller organizations who may have limited staff and resources to dedicate to data analysis? And how can smaller employers assess risk, you know, vis-a-vis, you know, larger employers like WPS? Can you help us with that?
Yeah, it's a tough question. I'll make it, you know, somewhat quick and to the point. One, you have to have a good advisor, and you should be asking that question of your advisor. How can we assess risk? If their answer is you can't because we can't get precise with the data, that's just not true. Today we have technology that has come into the marketplace that allows us to get better data even on fully insured groups. If you're self-funded and your plan administrator is not providing you with enough detail for you to make decisions and do things like what Dan is doing, even at the size under 100 employees, you can do and take steps like what Breakbush and Team Sherrill have done. And that would bring me back to a parting shot that I'd like to make, and that is, to Candace's point, data can seem like drudgery. To Sarah's point, once you get into it, you can become addicted. I'm an addict, but let's not forget the why. There's a great why here in the fact that fiduciary responsibility is even under more scrutiny. I'm fresh off a conference nationally with Health Rosetta. We know that the Department of Labor is going to start looking at employers more now under the CAA, and there are going to be more requirements to be a fiduciary, to be responsible as a fiduciary of your plan. But that's not a great enough why, if you ask me. What we can't forget in all this discussion around data is we're talking about human beings. And getting people the best possible outcome is the focus of all of our plans, regardless of the cost. You need to be able to, number one, first and foremost, understand that it is your responsibility to get the data, because without data in anywhere in your organization, you can't manage what you don't know. Plan has to start there.
Yes, thank you. Jeremy, a parting thought from you?
No, I agree with everything the panelists said, and I think it was a great, I appreciate so much for having me be part of this. I agree with everything Drew, Sarah specifically said. You know, a big component of this, and I'm agnostic when it really comes to advisors, but make sure that the advisor is working for you and getting you what you need. And part of that is being a good TPA partner, and your advisor should be able to find you that good TPA partner that's going to be able to help meet your needs. So I just thank everybody for being here, and thank you so much for the Alliance for hosting this and having me.
Thank you. Thank you all. Thank you to our speaker, Ryan, our panel of experts, everyone who attended and participated in today's webinar. We had more than 200 people registered for the webinar, so thank you very much. You will all receive an email following today's event, which has a short survey, and we appreciate any feedback you may have, as we always work to improve these events and bring you as much value as possible. Also, there's going to be directions on our website, on the email you will receive, on how to apply for CE credits. The presentations from today's event will be made available on the events page on our website. As I said before, we are open to helping and advising, so please call us, even if you're not a member, employer owner of the Alliance. We want to help. We love convening great people, as you've seen, great experts. So we would love to point you to a direction. Please remember to save the date for Tuesday, October 25th. This will be our fall symposium and annual meeting. We will be live and in person at Monona Terrace in Madison, Wisconsin, with a lot of great networking opportunities. The program will also be streaming live. It will be broadcasted online. Our keynote will be discussing the current economic climate and its impact on employers in Wisconsin, with recommendations on what employers can do specific to healthcare. We will have a panel of independent healthcare providers, an incredible team of people that we at the Alliance are working with, and they will discuss why they opted to deliver care outside traditional systems. And in fact, what is their mode of delivery? What is the impact on cost and quality? So please don't miss that. I want to thank you for the privilege of your time today, and that is all from us today. I will see you soon. I will see you October 25th. Thank you.